This is Dr. Mary Chamberlain, and I am here with Dr. William Darrow at the Centers for Disease Control and Prevention in Atlanta, Georgia. The date is November 6, 2017. I'm interviewing Dr. Darrow as part of the Oral History Project, CDC's Early Response to AIDS. This is the second interview with Dr. Darrow. Dr. Darrow, do I have your permission to interview you and to record the interview?
Yes, you do.
Well, Bill, during our first conversation, we ended in the midst of your recounting of what became known as the Los Angeles cluster investigation. So, to briefly reset the scene, it's March, April 1982, and there's still some uncertainty as to how this new disease is being transmitted. The Los Angeles CDC EIS officer, Dr. David Auerbach, had reported to the task force in Atlanta that he had become aware of 4 men in LA with AIDS who had been sexual partners. You and Dave then set out to assess the social and sexual relationships for as many as possible of the 19 cases of AIDS in gay men that had been reported in Los Angeles at that time. Ultimately, you obtained information through interviews for 13 of the 19. And among the key findings, you established sexual links between 9 of the 13 cases. 4 of the men, interestingly, named one man as a sexual partner. He was not from California. He was a Canadian air steward and had been reported out of New York City as an early AIDS case. Because this man appeared to link cases in New York City and Los Angeles, you extended the investigation beyond Los Angeles. And then ultimately, 40 cases of AIDS in 10 cities were linked to this one individual through sexual transmission. So, lots of cases, lots of sexual contacts, spread out over lots of cities. In the first interview, you described how you developed a diagram to illustrate all of this. So can you recap for us how you graphically diagrammed these linkages between the men in the cluster? Because it was a lot of information to try and condense down into something visual that people could take in at a...
Yeah, indeed, that was a major problem, was to how to represent these linkages between men from different parts of the United States to try to illustrate how they might have become infected, became very seriously ill, and later on died. So I was very fortunate because after completing my master's degree in sociology at the University of New Hampshire, I came back to CDC and I wanted to continue studying the social and behavioral aspects of sexually transmitted diseases. And a gift was given to me by Bill Watson, which I think I mentioned in my last interview. Bill came into my office one day and he said to me, you know, we've had a lot of social and behavioral scientists come to CDC as consultants to advise us on how we should proceed with our epidemiologic and other kinds of research, taking advantage of sociology, anthropology, psychology, the other social sciences. But we have found their advice, their suggestions to be less than satisfactory because they really don't know CDC and how we have to operate. They don't know the political climate, how we have to adapt. So we've decided that instead of getting outside consultants who don't know anything about CDC, we're going to have somebody from CDC go back to school, get a PhD in the social sciences, and then continue on as a staff member, and we'd like for you to be that person. So he asked me to walk on down the street to Emory University and get enrolled in their sociology program, which I did. While in that sociology program, I had the good fortune to take a course in social research methods. And it was during that methods course that Professor Marty Levin, Levin, talked about his work with Dr. James Coleman at Johns Hopkins University and later at the University of Chicago. Dr. Coleman was a social scientist who wanted to use mathematics and later wrote a book on mathematical sociology that Marty Levin, as a graduate student, helped him with. But before that, he worked on another study called the Adolescent Society. And in the Adolescent Society, he came up with this measure of connections between, in this case, high school students. And he called it the Homophily Index. So Professor Levin introduced us to the work of Dr. Coleman, Dr. James S. Coleman, and told us how about the Homophily Index, how to calculate it. We might want to use that in our research. And he also told us about another book called The Adolescent Society, which he advised us to read in preparation for our comprehensive exam. So I got a copy of The Adolescent Society, read it, and I think it was chapter 6, where associations among high school students were illustrated with something called sociograms. So this is the way they illustrated it, by showing nodes in a social network, those were the people, in circles, and then lines of varying distance and various density to show the nature of the connections. So I had that information as a graduate student at Emory, getting a PhD in sociology, when I graduated in 1973 and came to work for CDC. It took, of course, a few years later before I could see how it was relevant to what we were doing in the early 1980s, as you say, in March and April of 1982, when we started collecting information about the relationships between men that included sexual relationships, some of which occurred in the not-so-distant past, and others quite distantly, 4 or 5 years in the past. We didn't go beyond that, Mary. We had no idea the length of incubation, how long it was going to be between exposure to an agent, if indeed an agent was involved, and the manifestation of symptoms. And it took, quite a bit of work later on. So we guessed. And based on what I knew about sociology and sexual relationships, most people can't remember what they were doing in the past month or the past year, never mind the last 10 years. So we really didn't explore too much beyond 3 or 4, can you remember, 5 years ago? So those were the kinds of questions we were asking. We were exploring their socio-sexual relationships. How many different partners did you have in the last week, in the last month, in the last year? Can you remember in the last 5 years? That kind of thing. Before we got around to the business of, can you remember any of these people? What were they like? Where did they live? Where did you meet them? And then eventually around to the point of naming names. So once we started getting these names, which I talked about last time and can talk about some more, we had to illustrate this in some way so that we could show our colleagues at CDC so they could see the patterns that were beginning to emerge. That's when I remembered my work in graduate school with Professor Levin, the Homophily Index, mathematical sociology, sociograms, sociosexual networks. So with the information that we initially collected in Los Angeles, Dr. Auerbach and myself, and then with colleagues in New York, and you were working in New York at the time, so you knew many of these people, I tried to illustrate this to my colleagues here at CDC, initially in the form of these sociograms. And they seemed to work quite well. It was quite convincing to some of them. Others, of course, were skeptical. They should be. They're scientists. But some could say, oh, wow, now we begin to see the patterns. So it began to make sense to some of my colleagues here.
So a person was depicted as like a circle, if you will.
A circle, right.
And then lines were drawn to connect them to sexual partners.
Right.
I remember looking at the diagram as it subsequently was published, and it in some ways almost looks like an organic chemistry molecule, if you will.
Right.
And then I recall that in the circles you indicated by abbreviations the I guess it was the location of their diagnosis.
No, it was the diagnosis. Because even then, we didn't know if the cause of Kaposi's sarcoma was the same as the opportunistic infections or CMV. They had these different manifestations of what we later on called acquired immune deficiency syndrome. All of this was happening at the same time. So, one of the questions was, well, are these cases really connected? Some are developing cancers, some are developing opportunistic infections. At the time, the disease was known as pneumocystis carinii pneumonia. A lot of patients were developing this, as well as some other very strange diseases. They seem to be linked by this underlying immunosuppression, but we didn't know. So I indicated the cases by numbers, Los Angeles 1, Los Angeles 2, in terms of sequence of diagnosis.
Okay, so they were ordered
And
by
then by
diagnosis.
color, purple if it was Kaposi's sarcoma,
Yes.
yellow if it was CMV or something like that. So both of those things were indicated, you're absolutely right. And then the lines were to show that there had been, within the past 5 years, at least one sexual contact that could be confirmed.
Right.
That is, it wasn't just telltale that A would name B. If A would name B, we made every effort we could to talk to B or somebody who knew about B to see if B would rename A so that we could confirm the link, that it wouldn't be just hearsay evidence, but there was some solid evidence that indeed there was an exposure.
Now, how did you deal with the individual who had been named by several people as a sexual contact? The man that appeared to link the cases between New York City and Los Angeles, ultimately 40 cases of AIDS in 10 cities linked back to this single individual. As you say, all of them had named him as a sexual partner, and I presume he named them as a partner based on what you've said. How did you designate him in this diagram of relationships?
Well, let me go back a little bit to say that in March, Dr. Auerbach, March 1982, Dr. David Auerbach called Jim Curran or Harold Jaffe or somebody on the task force and said, "You won't believe this." But one of the men that I talked to recently said there are 3 different men that he knows very well, all dying of the same constellation of immunosuppressive disorders. All of them are in the same hospital at the same time, and they all have had sexual contact with one another. So that was 3 of the 4 that you mentioned in your introduction.
Okay.
Dave already knew about those. And then the response came, well, we really need to follow up on this. How about other people in the area? Are they also involved with these 3 or others? And Dave said, well, I haven't gotten that far yet. And they said, well, you might need some help with this. Is it okay if we ask Bill Darrow to come out and help you? And he said something to the effect, yeah, I can use all the help I can get. So I was asked to go join Dave, and as you say, there were 19 cases that he knew about in the Southern California area. 13 were either alive or there was somebody who knew very much about their intimate sexual behavior. So we tried to talk to all 13, Dave and I, together, so we could hear and help each other out, you said this and so forth. So all of those interviews were done by the 2 of us on one day. I think it was April 6th, 1982, but I really need to have that confirmed. It was something like April 6th, 1982. David set up 3 interviews.
Okay.
2 at the West Hollywood Health Center and a 3rd in Orange County with 3 different men who had never met, but all of whom were among these 19 who had been diagnosed.
Okay.
The first one, I can remember them all. The first one we interviewed was trying to be as cooperative as possible, and then we got to the point, well, can you remember any of the people that you've had sex with? Do you remember their names or something about them? And the first one said, oh, yes, one of my former sex partners was this extremely handsome, lovely young man who flew for Air Canada. He was a flight attendant. The second man that we also interviewed in the same facility early in the afternoon was a flight attendant himself. He worked for another airlines. And he said, yeah, I've had sex with other airline stewards, including this extremely handsome French-Canadian guy that flies for Air Canada. 2 of them mentioned this person on the same day. That night, Dave and I were tired, and this is written up in Randy Schultz's book. We're tired, and he said, I'm so tired and I'm so hungry. Let's stop in Chinatown on our way out to Orange County and get something decent to eat, because it's going to be another late night. Because we were trying to get all this work done in a week to save the government money, of course. So we did. We had this nice meal in Chinatown. Then we went out there, and we met this fellow who had recently been diagnosed with Kaposi's sarcoma. And he was very nice, and we sat at his picnic table. He had a picnic table inside his house, and we sat there talking to them. And we got around to the point, well, can you remember any of the people that you've had sex with? And he said, well, I remember somebody really well because I had sex with him twice. The first time I had sex with him, I'm pretty sure he gave me hepatitis B. And the second time I had sex with him, I'm pretty sure he gave me this disease that I've just been diagnosed with. And we said, okay, can you tell us who he was? Can you tell us anything about him? Oh yeah, he's a very handsome guy. You know what? I've got his name and his telephone number in my address book. Give me a few minutes, I'll go find it. So we're sitting there, and Dave and I are talking, and he comes back and he's got this name and he says, here it is. And when he tells us the name and tells us about him, I remember I dropped my pencil. Dave almost fell off of his chair. I think he actually did fall off his chair. You'll have to ask him. But we looked at each other with our mouths open and said, how could this be? The same person is named 3 times. Now, later on, when I came back, I looked and I noticed that Mary Guinan had interviewed this guy in New York, and he was patient number 57.
New York City case 57?
No,
Or CDC?
AIDS case 57.
National case number.
Because we counted them consecutively.
Right.
So the first case that
Very
CDC
early.
found out about was patient number 1. So he was the 57th person reported. Now, when I had to write this up, we had 19 cases in Los Angeles. So we called them LA1, LA2, LA3 based on the date of diagnosis. The earliest diagnosis case I changed from whatever it was, it might have been 335 or something like that, to LA1, LA2. Well, what are we going to do with this guy who's not from LA? I said, well, let's call him the out of California case.
Okay.
Because we know he's out of California. He appears to be a French Canadian living in New York. He travels a lot. But let's just call him the out of California case. So let's call him patient O for outside of California. So then we have this O that connects two parts of the cluster, which is very important because you say 9 patients were connected together, but 4 were connected together and 5 were connected together, and we couldn't put the 4 and 5 together without this patient
guy.
who came from outside of California. So initially we called him outside of California, and I have a document that I can show you where I scratch out patient 57 and circle the letter O
Put the letter
to
O.
designate him. And then when I started talking to my colleagues at CDC, I referred to him as patient O, the outside of California case. And everybody said, oh yeah, patient 0. I remember you reporting about this. So very quickly his identification transferred from patient O to patient 0. It happened within a matter of weeks, if
Oh,
not
really?
months. Yeah.
Okay.
So everybody on the task force was referring to this guy named patient 0. I said, who are you talking about? We're talking about the guy that you described. I described him as the out of California case.
Oh.
So then I had to give up, you know. By then, once he had a nickname, so I started calling him patient 0.
So the first, the initial, if you will, transformation of patient O to patient 0 happened within conversations, discussions about the LA cluster investigation within CDC.
Yeah.
I didn't appreciate that because I thought it originated outside of
No,
CDC.
it happened inside of CDC over the ensuing months.
Right. Okay.
So that by the time we wrote it up and published it in 1984, well, let me go back. There was an MMWR article.
Yes, there was.
That came out shortly thereafter.
June 82.
Exactly right. But that was just the LA cases, because the next step was to develop a protocol and instruments and get clearances and permission from the New York City Health Department to follow up on this lead, because this out of California case was not living in California, obviously, no longer living in Canada. He was living in New York at the time. So we wanted to follow up, and we learned very quickly that he was a patient of Dr. Friedman Keene's.
In New York City.
And he was being followed for Kaposi sarcoma there. As I told you yesterday, he was initially diagnosed in Canada, and he had lymphadenopathy he was diagnosed with lymphadenopathy as early as 1979.
So,
And when I looked at the medical records that Dr. Guinan had gathered, he was complaining of swollen glands as early as 1976. Now, I don't know if that was connected with hepatitis or some other illness, but on his medical records, he had a long history of having health problems.
right. Now, the MMWR did not contain a diagram in it. It was just text.
Right.
And that initial diagram that was put out in the public domain was in the American Journal of Medicine article that appeared in 1984, I think
Right,
it was.
1984, yes.
And that did have a diagram.
Yes.
And in that diagram, the node that represents the Canadian air steward, who's linking the two coasts, if you will, in terms of cases via sexual contact, his code is not an O for patient outside of California.
It is a 0.
Do you know how that transformation occurred?
I don't.
I mean, you have to look carefully because the fonts are such
Yeah.
that, I mean, I literally pulled out a magnifying glass when I relooked at that paper to convince myself that I was reading the number 0
Yeah.
and not capital.
I probably had an O because I tried to use the O as long as possible.
So you formally referred to him in documents or presentations as O, patient
As the out
O.
of California case, right. Right. Because LA1, LA2, O makes sense. I mean, they're letters.
Right, exactly, right.
To me, it made sense to me.
Right.
But what happened, you know, there was this baseball player named Lawrence Berra. Everybody knew him as Yogi.
Yogi.
After a while, you don't call him Lawrence.
Lawrence,
You
that's
call him
right.
Yogi.
Right.
And that kind of happened with this patient 0
Okay.
story. After a while, I give up. You want to call him patient 0, fine with me. We'll call him
Okay.
patient 0.
And-
But it was never meant to mean that he was the origin of the
what I was
epidemic,
gonna ask.
that he was the first case.
Case.
We never intended that.
Right.
We just wanted to show that there were connections among these men based on sexual exposures, suggesting that this might be a sexually transmitted disease. We didn't even want to suggest that one infected the other because we had no data to prove that. We couldn't.
There was no
It was
test.
all retrospective.
That's right.
So we didn't want to push the envelope more than we should have.
Uh-huh. Okay.
We tried to be very honest and very straightforward. But look, this data was so convincing to some of us that you had to begin to think that it wasn't nitrite inhalants that was causing the problem. It wasn't a genetic defect. It really looked like an infectious agent. You know, if it begins to
Transmitted
look,
sexually.
yeah, it looks. If it looks like an infectious agent, hey, you know, let's pursue that angle and let's stop, you know, following paths that are not going to lead us anywhere. I think that was generally the way the thinking went after the cluster investigation and the illustrations of these connections.
And indeed, in the American Journal of Medicine article, and the particularly, and somewhere in the MMWR, you do have text in there that states what you just did, which is that this is not to imply that we have identified this central node in our diagram as being the origin of even the source of infection for people in this cluster, let alone nationwide. So that was described. However, perceptions about this man and his role in the epidemic certainly took on a life of their own, if you will, because the moniker patient 0 that you and your colleagues used when discussing him, as you said, in-house at CDC, began to be used in the more popular media and press, and in particularly in the book that Randy Schiltz, this gay San Francisco journalist, wrote in 1987 and the band played on. He also refers to this case as patient 0. And there was a subsequent HBO movie based on the book, and patient 0 is a central figure in this. So when Randy was writing his book, did he contact you and others at CDC for information, not just about the cluster, but certainly that would have been an area that he was interested in? Did you all talk with him?
Yes, we did. He called here quite a bit. He was working for the San Francisco Chronicle at the time, and so he was an investigative reporter, and his beat was AIDS. As far as I know, he's the first person who was assigned to look at all the aspects of the AIDS epidemic. And I think his assignment went back to 1982. It was very early in the sequence. And so he started calling people, including me, other members of the task force, from 1982 on. He also came to CDC. He made a visit. And he arranged that visit with the Office of Public Affairs, I believe it was called at the time. And Don Barrett was the main contact at CDC. Our, as far as I was concerned, our head information officer.
Right, he was the head of that office.
And Don Barrett talked to those of us who had been working on the task force and said, look, this investigative journalist, Randy Schultz, is coming, and he wants to speak with you, and I want you to speak with him. He wants to have private one-on-one interviews. He may ask you to tape them. I hope you'll consent, and I hope you'll be extremely truthful and honest with him. Don't hold anything back. And I very much admired that position that he took, because at the time there was a lot of controversy in the press and in the public forum and even in Congress about what was going on, this gay disease, all kinds of stigmatizing comments and so forth. But he wanted us to be very open and transparent. Many of us spoke with Randy when he came to collect information for his book, and I spoke with him in private, one-on-one.
You did?
During that period of time, I did. And he said, do you mind if I record this? And I said, quite frankly, I'd rather that you not. What I would prefer is that you take notes, and that before you quote me directly, you give me the privilege of at least reviewing your notes before it becomes public record. Will you do that? And he said yes, and he kept his promise. So he sent me segments of his book before it went to publication, and I had a chance to comment. And he changed some things, other things he didn't change. I remember one of my major recommendations was, Randy, I don't think you should be naming all of these people.
Oh, because he used real names.
He used real names. I said, you can name me and you can name other members of the government. You know, we're fair game. You can quote us if you've got the quotes, but you shouldn't talk about people that you met in bars and bathhouses and as part of your public life in San Francisco. I don't think that's appropriate. I think you should use pseudonyms. He says, I can't do it. I can't do it. This has to be all truthful, and I'm going to take my role as an investigative journal, and I'm going to do that. And I said, okay. But, you know, that's your decision. My suggestion to you is that you not do it. I didn't like that. I didn't think it would be appropriate.
So he questioned you about the LA cluster
in great depth.
In great detail.
Yeah, and I can remember because David Auerbach said, oh, you're going to talk to Randy? I've already talked to him, and he knows everything. And then David said after a brief pause, everything.
Yes, he knew he had the name of the
He had already
Canadian.
gotten it from some other place.
He had gotten it from some other source.
Yeah.
Can you recall if at the time he was referring to Miss Patient Zero, or in the course of his
No, I don't think he did. I think he referred to this French-Canadian airline steward. I understand you met him and talked with him. I said, yeah, in New York, not in Los Angeles. But he knew a great deal about this. And it wasn't so much, I think, because we had been talking to reporters and the public. It was in-house communication and also with our colleagues in the Los Angeles County Health Department, San Francisco, New York. You worked in New York. I mean, those of us working for CDC were communicating constantly, as you may recall.
Yes.
And we tried to be very circumspect, and we tried not to use names. We tried to protect the confidence of the information that we had. But sometimes, in order to expedite the investigation, we did use names. Had to. So, you know, in our conversations. Or we used the patient numbers, you know, patient 57
Yes,
it would have been.
that's right.
It wouldn't have been LA1 or
Right.
patient 0 or patient O. So I don't remember, you know, talking to him about patient 0. But I do remember talking to him about the LA cluster and the follow-up work
Okay.
that I did in New York until I
Okay.
was assigned to do other things.
Do you think Randy's book and the band Played On contributed to this wider dissemination of this individual being known as Patient Zero?
Definitely.
Yeah.
Because he names them and he describes them throughout the book.
Right, and he calls him Patient Zero, and I have to.
And he gives his name, the name that he had, so that everybody knows this person now by his name, not
By his name, right.
Not And you know there was a book that was published by Fettner and Czech in 1984 called The Truth About AIDS. And in there, there's a discussion of this French airline steward who had many different sex partners.
Oh, really?
And they say, let's call him Eric. So they used a pseudonym in 1984, 3 years before Randy published his book. And then they go on to tell the story of Friedman Keene being in San Francisco, talking with Dr. Mark Conant, and Dr. Mark Conant telling Friedman Keene on the telephone, or I guess it was in person at the time, oh yes, I've met this guy and he's got a date with one of our doctors here.
Oh my God.
And then so that in the book by Fettner and Czech, Friedman Keene allegedly called his colleague Linda Laubenstein in New York at New York
NYU
Hospital and said, I found our typhoid Mary.
Oh.
But calls him Eric. Doesn't call him patient 0, doesn't call him the out of California case, doesn't call him patient 57, calls him Eric.
Oh, how interesting.
A pseudonym.
So again, in just trying as best we can to look back and see how patient out of California becomes patient 0, to recap, within CDC in-house discussions, the moniker patient 0 was used, but in official publications, that tag was never used. He was never referred to as patient 0 in any of the documents that you published.
Not before 1984. In 84, he is, it looks like patient 0, but it is
in the American
it's not spelled out ZERO.
Right.
It was never spelled out ZERO.
I was going to say that in the American Journal of Medicine article.
Right.
That
there is
the diagram
this circle.
he's called. It says patient 0. It's
O or
the
0.
0, and there's a key. You have a key.
Right.
That you explain the abbreviations, LA equals Los Angeles, SF equals San Francisco. And I think the number 0 is identified as index patient.
Yes, and let me explain that, because it didn't mean that he was the first case. What it meant was it would have been impossible to connect cases between the West Coast and the East Coast without the information that he provided.
Okay.
See, that's the other thing. He was more generous than anybody else in providing information to me and to other members of the task force. He was very open. I think I recounted last time about how after I met him and interviewed him in person in Dr. Friedman Keene's office, he told me that he had an address book.
That's right.
With all the names in it. And I said, oh, I would like very much to see that. May I go back to your apartment? He says, oh, no, I've got other things to do. I've got errands to run. But I'll call you and I'll tell you the information that's in there. I said, okay, fine. When are you going to call me? He said, well, I don't know. I said, can I call you? He said, yes, but you can only call me between 6 and 6:30. And I said, okay, fine. I'll call you around 6 o'clock, and then you'll give me this information. He said, I'll be glad to. I'll be at my apartment then. I've got to go out tonight, but we can do it then. And I called him from Grand Central Station while I was waiting for a limousine to take me to the airport to return to Atlanta, to CDC. And I was able finally to get one of those payphones and to speak with him. And I actually wrote down all the information that he gave me at that time while waiting for the limo. And then he said, 6:30's here, I've got to go. And I got the names of, I think it was 73 different people. Or I got some information about phone number, a nickname, something. And I could see that they were from all over the country. They were from Texas and they were from Georgia. They weren't just from California or New York, although most of them were from California because he had recently updated his book. And if he hadn't done that, I might have gotten 100, 200, 300 different names. Nobody else had provided such extensive information.
I was going to ask you about that because after the release of the book and perhaps other media, public press things, patient 0 was portrayed as a real villain, a scapegoat, someone who was knowingly spreading disease to his partners. And I wanted to ask you about, in terms of your interactions with him, did he come across as someone
No,
like
not
that?
at
It
all.
sounds
He came
very different.
across as a person who was very much concerned about his own health, about the health of others, because he knew many other people who were very sick, and some who had already died. And he did, I think the last thing he wanted to do was to spread the disease to others. And I said to him, you know, we don't know for sure what's causing this, but it's increasingly looking like an infectious agent, a pathogen, a germ, something that's being spread from one person to another through unprotected sexual activities. And he said, whoa, what are you talking about? I've got cancer. There's no cancer that's spread by sexual contact. What are you talking about? You know, this is not gonorrhea, this is not syphilis. Now, he wasn't using those terms, but that was what was going through his head. And I said, just because we haven't found any link up to this point doesn't mean it's not possible. And we now have to consider the hypothesis that this is a sexually transmitted disease, and you could have gotten it from somebody else. You could give it to somebody else. He says, oh my God, you know, if that's true, that's awful. But I don't think it's true. It can't be true because, you know, you're going too far now, essentially. He was very skeptical of that.
Okay, okay.
So I was unable to convince him that he should change his sexual behavior.
Yeah.
I mean, that wasn't part of our interview. When we talked for, I don't know, an hour and a half or so, and then we had to end. But at the time, you know, he wasn't convinced that it was sexually transmitted. Now, from what I understand, other people did confront him directly, including some medical officers in public health, and said, look, this is sexually transmitted, you got to stop. And he said, you know, I'm not convinced. I don't think so, from what I've heard. But that didn't happen in our conversations. And I did speak to him a number of times after that on the phone. I never met him again face to face, not even when he came to CDC.
And he came to CDC for what reason?
He was called back to donate specimens. I think it was Dr. Harry Haverkos, who was instrumental in getting him to come to CDC to collect all kinds of specimens. Because at the time, we thought that he might be, you know, a transmitter, and there might be something biological that we could find that might suggest why he was transmitting. And I don't know exactly when that happened. I don't think it happened before 1985 when we were pretty sure what the agent was. You know, but as early as 83, it was looking like there might be a virus involved from the work that was being done at the Pasteur Institute.
That's right. Well, that was very prescient, if you will, for Harry Haverkos to have him come to CDC and donate blood that could
And
be
other
used for
specimens,
study.
too.
And other specimens.
Yeah.
The myth of patient zero persisted for years, decades. And I went back and I was looking at excerpts from Randy Schultz's book, And the Band Played On, and I came across this quote. He writes, whether he, meaning patient zero, actually was the person who brought AIDS to North America remains a question of debate and is ultimately unanswerable. Well, turns out it was possible to answer that question. New research that was published in the journal Nature in October of 2016, so about a year ago, using advanced molecular genetic analyses, going back to the out of California cases specimen and other specimens from early AIDS patients that were available, using these techniques definitively established that so-called patient zero was far from the first or even a very early case of HIV infection in the United States. It turns out, and you obviously know this, Bill, HIV had been silently circulating and infecting people in the United States for more than a decade before cases were first recognized in 1981. What was your reaction to the study's findings, this Nature article that combined epidemiology and these genetic analyses?
Well, as a scientist, I was grateful to see them, but there had been some earlier reports that had been published based on specimens from patients seen at the University of Miami, mostly Haitian patients, and then some other. There was another follow-up study. So actually, studies of these kind had been going on for at least 15 years, and I think Professor Dr. Warabi was part of these studies. Of course, the techniques improved over time, and so more definitive results were forthcoming. And I was very happy to see this. Because as I said earlier, we never cared about the first case. I do care about when the virus first came to the United States, and the evidence that's available now suggests it was probably around 1968, maybe give or take a year or two, and probably came from Haiti to New York City. And it was in New York City for some time. And some of the anecdotal information that we have from studies of injection drug users and other populations seems to support that it arrived in New York around 1968 or so and infected a few people, but probably didn't get into the gay population until a little bit later than that. How soon, we don't know. Now, one of the things that I found when I was looking through my materials was a very interesting letter from somebody who had seen that Candy Darling died in 1973. Candy Darling was part of the Andy Warhol group that was here in New York at the time, and was in some of his films. Candy Darling died in 1973 and had cancer and some mysterious infections, apparently, according to this obituary that was clipped out and sent to CDC and that I have in my files. So, the question is, could Candy Darling have been one of those early cases? Well, that's kind of interesting.
It is.
Might have been. But there might have been lots of others. All of that is now seeming possible. But we don't have specimens. I mean, how are we ever going to prove this or disprove it?
Right.
We can't. But it is interesting to speculate. About the French-Canadian steward, it didn't seem possible for him to be the early case because he was 21 years old and working as working in a hair salon when he decided to become a flight attendant. And I think it was in Quebec. He's still in Quebec, where he was born and raised in 21, and at the age of 21. And this is 1973. And then he decides to go to Vancouver to learn English a little bit better so that he can apply and become an airline steward. And I don't believe he started flying until 1974. He could have been infected in Quebec City, but it's much more likely he didn't until he moved to Vancouver, because he was one of the first cases ever found in Vancouver or connected with Vancouver, but more likely even in 74. So he's diagnosed with lymphadenopathy 5 years later and Kaposi's sarcoma 6 years. Well, now people say, well, that's not impossible because the average time is 8 to 10 years. Well, back then there were some cases who developed very early on, as you may recall. There was even a case from Australia where the exposure date and the onset of AIDS was about a month. So there were some very unusual cases like that. But it just didn't seem to fit that he would be the first case. Never seemed that way to me. So I was very happy to see all of this additional evidence discounting that. And I think it's just a shame that his family has had to suffer. The stigmatization that seemed to come with it, with people casting aspersions and pointing blame at this person who, if he hadn't cooperated with us and hadn't done some of the things that he had done, we might still be in trying to find out answers to questions. So it's regrettable.
This Nature October 2016 publication generated a tremendous amount of media interest, television, print, lots of headlines about patient zero, myth debunked, whatever. You, I know, were interviewed several times about this. Were you surprised that this
I
Was such a
was. I was
splash?
surprised, but I think Donald McNeil Jr.'s article in the New York Times gives a clue as to why. Because in his article about the ethics of finding patient zero, he raises the question, why are we so curious about the first case? Why do we want to know who is responsible for these epidemics? And that seems to go back, well, Typhoid Mary, of course, didn't start the typhoid epidemic. And there were, at the time that she was diagnosed, there were about 500 other cases of. Why is everybody so concerned about Mary Mallon, this horrible person who was spreading typhoid, when other people had typhoid and were spreading around? So there's a long history of trying to cast blame on some person or some event or something and say if that hadn't happened, then we wouldn't have these problems. And I think Donald McNeil Jr.'s article in the New York Times does a wonderful job of describing that, because he talks about influenza epidemics, he talks about the Ebola epidemic, and how each of these has been traced back to a certain space, a certain place, a certain person, and so forth. And a book recently was published on the great influenza epidemic, the Spanish flu of 1918 and 1919, and where did that begin? Well, it began in the Midwest, Kansas of all places, but nobody got blamed for that except the Spaniards, and the Spaniards got blamed for it because they didn't have many cases. It's ironic.
It is ironic.
Yeah, so I was very much surprised, but I think Donald McNeil's article goes a long way toward explaining it. Whenever there's a disease, somebody wants to say, okay, who's at fault?
Who is it for? Well, fascinating, Bill. I'd like to move on and ask you, because I know you had many other projects, unless you have any closing comments about the LA investigation, I wanted to ask you about some of the other work that you did at CDC, because you did work about AIDS research that extended beyond studies of the disease in gay populations, and I wondered if you could tell us a little bit about some of those studies and the work that you did.
So, starting with the case control study, AIDS project number 1, CDC kept count of the studies that involved the collection of specimens. So I didn't collect data as part of CDC AIDS Project 1, but I was assisting with the development of the protocol, the questionnaire, pre-testing the questionnaire, training the interviewers, even wrote an article about the interviewers and their success, and published it in Archives of Sexual Behavior to show people who thought that women couldn't interview gay men about these kinds of things and so forth. That was all dispelled by the Polly Thomas and other people who worked on this. So I wanted to show that different young medical officers, it didn't matter what their gender was or anything, they could be trained and they could do a very good job of collecting highly sensitive information. So I did do that as part of AIDS Project number 1. I worked a little bit on number 2, which was AIDS cases outside of the 4 major areas where we did the case control study. So that would be New York, Atlanta, San Francisco, and Los Angeles. And then the cluster study was called CDC AIDS Project number 6.
Oh, that was number 6, okay.
That was number 6. And we collected specimens, David Auerbach and other medical officers that I was working with collected specimens there and in New York City. Because what we were interested in doing in New York City, or what I was interested in doing in New York City, and I got permission from the health department to do that for a while, was to talk to all the people who had not been reported as having AIDS that were on that list of 73 people, to see about them and their health, to see if they had any indications that they might be sick and had not yet been reported. And that turned out to be very fruitful, because I can remember talking to some of those contacts that had been named by patient 0, or the out of California case, and at the time they were perfectly all right, and then I checked back later on and they were diagnosed, they came down with AIDS, which gave further credence to the hypothesis that it's a sexually transmitted agent. So that was AIDS Project 6. The next big project that I got involved with shortly after the cluster investigation wound up in 1982 was the follow-up of the hepatitis B cohort.
Ah, yes.
So from 1976 until 1981, there were a series of studies done by CDC on the prevalence, incidence, and the effectiveness and safety of a vaccine for hepatitis B. And Don Francis was very much a part of that, as were other colleagues working in venereal disease control, which later on became STD, or sexually transmitted disease control. So I was involved in that from 1976, the planning of that, 1975 actually, and 1976. And I would do various things in conjunction with that, even though I wasn't a lead author, or, I assisted with that. So in 1983, because Paul O'Malley, who worked on the hepatitis study, called me up one day and said, "You won't believe this, but of the first 10 cases of AIDS here in San Francisco, 6 were part of the hepatitis study." Do you think there's any possibility that there's something in the hepatitis vaccine that's making them sick? He actually said that over the phone.
Wow.
I said, "Paul, I didn't know that. We need to follow up." So from that day forward, so that must have been in 1981, from that day forward, we were interested in that cohort in San Francisco as well as the others. And then Don Francis, when he came here, and he wasn't here initially in 81, he came later. When the hepatitis lab moved from Phoenix here, and Don
To
came,
Atlanta,
Don said, "We really ought to take a look at those guys, because we have over 6,000 specimens saved from those guys in San Francisco, and if some of them are coming down with AIDS, that's really important, because we've saved their blood that we collected in 78, 79, and 80, and here it is 1983. Why don't we contact some of those guys and ask them if they'll give us more specimens so we can compare what's in their blood today with what was in their blood back then? And Bill Darrow, wouldn't you like to do this work? Because you don't have anything else to do." And Bill Darrow said, "Sure, I'd be glad to do it. I always like to go to San Francisco, and I've always had good relationships with my colleagues out there." So I started working on that, and that was CDC AIDS Project 24.
That was 20. And refresh our memory as to who Paul O'Malley was.
Paul O'Malley was a public health worker who joined the San Francisco Health Department after serving as a medic during the Vietnam War. I don't think he ever was sent to Vietnam, but he had training as a medic.
Okay.
And then after he left the Army, pretty sure he was in the Army, he went to San Francisco to get a job with the health department to continue that kind of work, and he ended up in STD control.
I see.
And when the hepatitis study came along, he was asked to head up that study, and he did a wonderful job. What a great guy. That's one of the real advantages of working in public health and at CDC. You get to meet the most wonderful people. And Paul and I knew each other from the earliest meetings on hepatitis B in 75, and we stayed in touch. And then in 83, if I got a chance to work with Paul O'Malley again, that's great, because he really cared for all of those men who were in that hepatitis study. And so he was a real treat to work with. So that's Paul.
Okay.
Paul was interviewed by Sally Smith Hughes as part of that oral history project they did at the University of California. Yeah.
And this study ultimately was reassuring in that it didn't indicate that the vaccine, hepatitis B vaccine, was
That's
a
correct.
source of infection, but it did provide important information about
extremely important.
the increasing prevalence of HIV infection in this cohort of gay men.
That's correct.
Because you had sequential specimens over time.
That's correct. We showed that the prevalence of HIV in the HBV cohort was very low, less than 5%, as I recall, in 1978. And when we started getting permission to test the bloods in 83 and 84, 2/3 of these men had antibody to HIV. And we couldn't do anything about it because the blood test wasn't really available until 85. Right. So it was all retrospective, and when it came out, I can remember presenting these data at a conference at NIH, and you could have heard a pin drop when I showed the curve of the prevalence of HIV antibody in this cohort. People were really frightened.
Did you do any studies in heterosexual populations?
I did, and that followed. That's CDC AIDS Project 72. Harold and Jim called me in one day and said, okay, Bill, you've helped us understand the epidemiology of HIV among homosexual and bisexual men. Can you help us understand the epidemiology of HIV in heterosexual and particularly heterosexual women? Because we know that women are infected. So let's focus on a group that has a large number of partners and uses drugs and so forth, and see what the prevalence is, and if we can get at the incidence, okay. And let's look at the risk factors, and let's look at ways of preventing transmission. And so why don't you design a study of sex workers, female sex workers? And I said, okay, if that's what you want me to do, I'll do it. So Project 72 was a study of female prostitutes in the United States, and we did it in 8 different places. We had we called for there was an RFA, and we made awards to as many places as we could, and we even got a few places to agree to do it with very minimal or no funding. Yeah, and one of them was Colorado Springs, and that's where I did a lot of my subsequent work for CDC AIDS Project 90, and that's where we really did some good social network research. And that was through the auspices of Rich Rothenberg.
Who was out in the Colorado Health
in
Department.
Colorado. I don't think he was still in Colorado at the time, but through the Venereal Disease Control Strategic Planning System, which went back to the 1970s, Rich was in Colorado and established a very good working relationship with the El Paso County Health Department in Colorado Springs, Dr. John Muth, and a guy named John Potterat, who was a former venereal disease investigator, public health advisor in Los Angeles. And John was very much interested in the dynamics of gonorrhea transmission at the time, when we were really interested in gonorrhea. And so when HIV came along, or when AIDS came along, he was very much interested in, is this in our community? What populations? And so when I approached John about possibly doing a social network study, I said, it's going to be a lot of work. He said, yeah, I'm all game, because I want to find out what's happening here. So that.
What did your study of U.S. female prostitutes?
Okay, so that would have been from 1985 to 1987, something like
still
that.
Early.
It was a cross-sectional study. And then we were going to follow it up with a longitudinal study.
Okay.
Try to get at incidence and prevention. And that was the idea for Project 90.
Okay.
So we first did the cross-sectional. We found that the main risk factor was not number of partners for the women. It was the use of injection drugs. Unfortunately, prostitutes that injected drugs were much more likely to be infected than those that never did. And secondly, sexual contact with non-professional contacts. In other words, with their lovers, their boyfriends, their pimps. That was much riskier than exposures to clients, where there was a much more likelihood of a condom being used or some kind of screening happening. But with their boyfriends, there was no condom, there was no screening, and sometimes the boyfriends used drugs. So that was the riskiest factor for infection among female prostitutes in the cross-sectional study.
I'm curious because your work on these very early aspects of CDC's response to the AIDS epidemic was happening at a time when there was a very conservative political climate in the United States at the time of the rise of the new right, the moral majority. Did the politics of the day in any way affect your ability to do your job or get you in hot water?
I got into a lot of trouble, yes. I have to admit that. Let's take the prostitute study, for example. Okay, I'm a social scientist.
Yeah.
And I'm trained that if you're going to study a population, a marginalized populations like prostitutes, you can't do it without having their input. It's only fair. It's ethical. It's the right thing to do. And of course, with a very conservative government, to even suggest that you might invite a prostitute to serve as an advisor, not only that, but to have the meeting here at CDC on government property and to have a prostitute in the meeting making decisions among scientists.
So this is a planning meeting, if you
Oh,
will,
it was
for
a
the study,
planning
when we
meeting for
invite
the
in
study.
experts,
Yes.
external experts.
As I said, we had 8 different centers involved.
That's right.
And we wanted to call them all in to talk about a common protocol that we would all be willing to follow, and a common questionnaire so that we could pool the data, so we could compare data from Atlantic City, New Jersey with Los Angeles, California. How are you going to do that if you got different protocols and different instruments? And it's a cooperative agreement, right? So they
Right.
can essentially do what they want. You know, you can twist their arms, you can't force them. So it all has to be negotiated. And are we going to do this just with public health people? To me, it didn't make any sense. We had to have some prostitutes or former prostitutes who knew what was happening out there, just like, you know, why would you do a study of gay men and exclude gay men? So to me, it made sense. So I invited a former prostitute, we'll say, that was recommended to me by Dr. Jackie Bowles, a professor of sociology at Georgia State University, whose field was the sociology of work. And one of the professions she was interested in was prostitution. To her, it was a job, you know, so she wanted to see how they managed their lives and so forth. And she said, there's this woman, I can name her because she didn't mind, Dolores French, who just published a book called Working. Why don't you go to Dolores and ask her if she'd be willing to come and provide advice, you know, become a member of the team. So I did.
An expert advisor.
An expert advisor. Well, I can tell you, when we had our meeting, I've never seen so many CDC interested in a scientific meeting as we did that day. Everybody wanted to see this woman of the night that we had called upon to advise us. And of course, I got called into the second floor office. That's where the
Office of the
Darrow,
director?
what the hell are you doing now? It's a miracle I was not fired. I had a number of occasions where things like that happened.
Well, one thing I wanted to ask you about is, in the time that you were working at CDC, again, in these early days, in the 80s, did you have any peer group in terms of other PhD sociologists? And if not, what did it feel like to, certainly on the task force, you were the sole sociologist amongst all these biomedical types. What was that like?
Well, I had a great time, actually. I very much enjoyed it because I had very good colleagues who, for the most part, were sympathetic. Some were not. Some were extremely skeptical initially of the anecdotal data that we social scientists seem to thrive upon. You know, they wanted to have more rigorous research, and so would I if I had the money and the support. But you're absolutely right. I think the reason that I was selected to join the task force was because there was nobody else available. They couldn't pick anybody else. They couldn't be choosy. So I was asked to join the task force in August of 1981 to help out while I continued to do all the other things that I was supposed to do. And it was because at the time, there might have been one or two other social or behavioral scientists around. I think Sevgi Aral was on the staff, and she was trained in sociology as I was. In fact, she was a classmate of mine at Emory.
Oh, really?
When I was there. And she called me up one day, and she said, well, she was a native of Turkey. She said, we're back here in Atlanta, and Mustafa is working at Georgia Tech, and I can't find a job. Are there any jobs at CDC? And I said, well, I think maybe there's a project that's being done, and you need to come and talk with Paul Wiesner and Ron St. John. I think they could use somebody like you on that project. And they were working at some health center. Stuart Brown was part of that. I think you know Stuart Brown.
Yes, indeed.
And I said, you know, you need to talk with Stuart Brown. And so they hired her. But she was going to, when I was asked to help the task force, she was going to help with all the other STDs.
Non-AIDS things.
Yeah, but if there were any other social scientists with PhDs, I can't remember who they were at the time. There might have been a few.
It's interesting because you comment on the sort of stereotype of the sociologist producing soft data, but I recall from our first interview that you talked about you actually knew your way around statistical methods and computer printouts and data analyses, so there wasn't, that's
Well,
not
that's a
soft.
very good point. I think that's why I was respected more than the fact that I was a social scientist. Because when I went to Emory, they used SPSS, the Statistical Package for the Social Sciences, in one of its earliest forms. I even remember the way you had to set things up. You couldn't have anything in the first 16 columns unless it dealt with this, and then you put everything else from 16 to 80. And so they gave me good training in statistics and in research methods. And so a lot of people were just beginning to use computers and didn't know. I remember working with Grady Waters. The name just came back. Yes.
Oh, yeah.
Grady Waters, and he had an assistant, and that was about it for the computer staff
They were the
here at the
computer staff.
time.
Yeah.
And I had taken a course in Fortran, and so I knew a little bit about programming. I knew about SPSS. I had some good training in statistics that was beneficial, particularly for epidemiologists. And so I could do those kinds of things. And so I was called upon to do that as much as I was to consult on sociological type things.
Interesting. The early days of CDC's response to AIDS happened at a time, there were lots of challenges on many fronts, and this interview and your early ones certainly highlighted some of those. When you look back, do you think there's any aspects of the response where CDC fell short or could have done a better job?
I think CDC did a marvelous job under the circumstances. It was like trying to fight Muhammad Ali with both hands tied behind your back. We were really at a disadvantage. We had to be very careful with what we did because we would have been open for criticism. On the other hand, I mean, there was a terrible problem going on. People were dying, and we couldn't get any support. So we had to be very careful about that. But all of my colleagues were really devoted to the mission. And the mission was given to us, we've got to find out what's going on in order to save lives. And we're not going to get much support. And if we don't do it, we don't think anybody else is. So we've got to do it. And so we did. And I never heard anybody complain about coming to work early and staying late, about traveling here, traveling there. It was mission-oriented research, and I think that's when public health is at its best. When you've got a mission, you've got to try to figure out what's killing people so you can stop it. And that's what we all tried to do, and it didn't make any difference at the time. If you were a microbiologist or an immunologist or even a sociologist. If you had something that you could contribute, you should do it, and that's what we did.
So the CDC's AIDS response has relevance even today to the public health challenges that still arise. There's lessons to be learned.
Oh, there certainly are. There certainly are. And I would say in some ways, at least for me, to do research on HIV/AIDS is more difficult today. We didn't have any money for anything back then. Now there's money for certain things, but it's pretty much going into the biomedical side. You know, people are still interested in developing vaccines. They're still interested in developing better treatments. We talked to Tara earlier. She's doing reresearch on better diagnostic tests.
This is current CD,
Yes,
a very young
current,
junior staff who's working.
Spending all of our time trying to develop better diagnostic tests. Where's the really good behavioral research? Where's the really good sociological research? I'm in a department of health promotion and disease prevention. And there's virtually no good research being done now on educating people about infectious chronic diseases, other public health problems. It's just thought, you know, what else is there to learn? There is so much more to learn, particularly in this age, the digital age of information technology. We don't really know how to use all of the things that are available to us today, like the biomedical scientists do. And it's because there's an absence of support for that kind of research.
Interesting. Bill, you were part of something that changed changed history in the course of public health. How has that affected you personally and professionally?
Well, personally, I can remember all the men who died, including some who died in my own house. That's a sad thing. So there have been periods in my time where I just didn't want to do this anymore. And then I remember them. Wonderful people. And so it's had a tremendous impact on me because here I am now with 55 years of experience in public health. And as you know, it's hard for me to leave. It's in my blood now. I've got the antibodies. I can't seem to stop. So personally, I feel as though I have to continue in their memory. Professionally, there have been good times and bad times. There have been a lot of interest in some of the things that I have been party to at certain times. But it's as hard for me today as it ever was to try to get grants to support the kind of research. There doesn't seem to be much interest in the kinds of things that I'm interested in and have always been interested in. And I still get papers rejected when I send them off for publication. So some things never change.
Well, you left CDC in 1994 and went to Miami, to Florida International University. And it's 2017, so you've had nearly another 25-year career. You're knocking on the door of another 25-year career. So you are like the Energizer Bunny.
Well, that's an interesting story, too, because I saw what Eugene Gangarosa and Phil Brockman and others were able to do here at CDC by offering courses on global epidemiology. And at the time, there was a nascent program in public health at Emory University.
That's right.
And now we have the Rollins School of Public Health, and the dean is, of all people, James Curran, my former boss. And so many of my former colleagues are faculty members there. And so I saw that happen. I saw that go from a core of about 4 or 5 people to a faculty of something like 400 or 500 today. And when I was invited to join the faculty at Florida International University, I was the 6th person to join that faculty that formed in 1985. And we haven't grown like the Rollins School of Public Health. But now we have I have 130 colleagues, and a dean with 6 different departments, and a program that offers a PhD as well as an MPH in public health. And we're expanding with undergraduate education and online education. And so I've had an opportunity to contribute to academic public health as well as to public health research, and that's given me a great deal of satisfaction as well. To see us at least follow part of the way along the path that I saw pioneers from CDC help do with our neighbors down the street.
Well, Bill, it has been an absolute pleasure to have this conversation with you, 2 conversations, in fact, and I have to say, commend you for your memory of events is just absolutely amazing to me. Thank you very much. Any closing thoughts? I'll leave the last word to you.
Well, thank you for doing this. I think it's wonderful that CDC has taken an interest in the history of public health. When I started my work in venereal disease control in 1961, I was exposed to the history of syphilis. And I found it fascinating. Of course, some things happened along the way that have been troubling and still interest me, like the Tuskegee study of untreated syphilis in the Negro male, as it was originally called. But our history is very rich. I now teach a course on the history and foundations of public health, where we recount many of the experiences the investigations of Joseph Goldberger on pellagra, and discovering that the cause was not an infectious agent, but vitamin deficiency. I mentioned the influenza outbreak and John Barry's wonderful book about the great influenza, and all of the historical things that have happened, and now to see CDC focusing on its very rich history, all of its contributions to smallpox eradication, to the recent investigations of Ebola virus, and you also talking about toxic shock, the toxic shock history, and here we are talking about AIDS. CDC has been involved in so many things. Polio, you say we're revisiting the polio scare, and I remember all of that. I had a cousin who developed polio at a very early age. All of that CDC has done, and I think it's just wonderful that that you and other people are recording all of this information for posterity, so that everybody will be aware of all the contributions that CDC has made.
Well, thank you, Bill. I think we'll close.